problem of internet and laptops, but we will try to solve at least one of these few problems, inshallah. If we can ask Dr. Wael to start. Dr. Wael, please, can you start now?
Thank you, Doctor. Assalamu alaikum. So welcome to our Astro contouring workshop on lung cancer. So my name is Wael Muhammad, as Doctor introduced me. And our teacher today, Dr. Ahmed Salim, he's a professor of oncology from Manchester University. And Mika is, all of us know about him. He is the organizer for that program. So what is Falcon? So Falcon is the Fellowship of Anatomic Delineation and Contouring. It's Astro Educational Contouring Program, and our aim is to improve your delineation skills, compare similarities between you and Astro guidelines contouring and expert contours. So why to attend Falcon events? There are inconsistency in delineation in target volume and critical structures, and the benefits of attending: improving contouring in daily practice, understanding consensus guidelines, and discuss contouring with experts. So our learning objects is to be able to justify your contours, to be able to properly apply the contouring guidelines, to increase your inter-observer homogeneity and consistency in contouring. Falcon Educase. So how to go to the case? I think we are going to distribute some laptops now to make in groups. So what we'll go through this website is through Educase, and I think you received already your membership login, and you will open the case of lung. So this is the icons for contouring tools, which we will go through it when we are applying the case. Just remember that you can use the window level tools to change from bone window to lung window. And you can receive also, you can go through the guidelines sent to you through how to do the Educase. And this is the shape of the program of the Educase. And you will use the your practice. You can see in the lower part of the screen. So the patient case. This is 71 years old lady. No, sorry, this is not. Yeah. So this is 71 years old man presented with cough and sore throat in 2013. He has a history of peripheral vascular disease and COPD and TIA. He is on clopidogrel and lansoprazole and perindoprel. So he is a retired electrician, and he is a 40 pack year smoking history, and he lives with his wife, performance status of 1, and he don't have other medical history significance. His FEV1 is 2.19. and FVC is 3.75, and his initial CT and PET scan showed this lesion, and the initial treatment has been diagnosed with a squamous cell carcinoma, activating mutation negative and staging T4 in XM0, treated with chart radiotherapy, 54 gray over 36 fractions. And he has re-irradiation in January 2014. When this is the recurrence in the PET scan. Again, rebiopsy following the imaging showed squamous cell carcinoma, and the PET scan confirmed 2.8 centimeter nodule in the previous radiotherapy field, with no notes and treatment with re-irradiation of 55 gray into 20 fractions. We are going to discuss the organs at risk and the contouring of the initial treatment and the re-irradiation contours. So the outcome was he has G2 fatigue and grade 2 breathlessness. Dr. Ahmed going to start the lecture.
تديني الورقة رجع لي الورقة. صباح الخير جميعا. أنا اسمي أحمد سالم. أنا جايكم اليوم من الأردن. ولكن يعني عندي أكثر من affiliations بالأردن، أكاديمية وكلينيكال، ولا أزال أحمل affiliation لليونيفرسيتي أوف مانشستر في بريطانيا. بس بدي أعرف منكم كم واحد هون radiation أو clinical oncologist؟ ممكن ترفعوا ايديكم؟ اوكي. كم واحد trainee؟ كم واحد physicist؟ اهلا وسهلا. في حدا ما في تخصصات تانية صحيح؟ ما في medical oncologist او surgeons؟ ما في. يعني احنا كلنا we are dealing. And are you all treating lung cancer? Are you all treating lung cancer cases? طيب, can I just have a show of hands? How many people do re-irradiation for lung cancer? Retreatment with radiotherapy. في حدا بيعمل retreatment? Just one. What institution, do you mind me asking? Ahmed Maher. طيب, anybody does SBRT for lung cancer or oligometastasis? Another, just one institution. طب احنا اليوم الحالات تبعتنا حتكون بشكل اساسي عن SBRT for lung cancer and re-irradiation. هلا مهم بصراحة قدر المستطاع انه تكون interactive session. please ask questions. There is no stupid questions. Actually, some of them we as faculty don't know the answers to, and it opens very nice discussions. It is also important to kind of highlight where are the challenges and why you guys are not doing re-irradiation or not doing SBRT. Is it because of lack of expertise or is it because of lack of equipment? هلا احنا شو هدفنا؟ هدفنا انه نرسم التيومر بالكامل اللي هو الجروس تيومر فوليوم، لانه احنا بنعرف انه حاليا اغلبيه الحالات احنا بنعالجها عن طريق الفي مات. وبالطريقة هاي drawing the tumor is very important to achieve optimal tumor control. Optimizer, organs at risk need to be drawn properly so that they are featured into the optimizer, and we apply those constraints for this. And this is important because toxicity is quite significant, particularly if you're doing re-irradiation, so treatment for the second time. And this has become much more important now with the introduction of highly conformal techniques. So like I said, now nearly all of the lung cancer cases in the institutions where I work in are treated with VMAT. And it's also more and more important if you use protons. And I give you an example here of the first case of protons which we treated and I was privileged to be part of in Manchester. So this is an adenoid cystic carcinoma of the trachea in a young female. وهون الفائدة الكبرى من البروتونز إنه you can spare bilateral breasts. You can obviously decrease generally the splash dose to other organs because these patients can live for long. بس المشكلة في البروتونز إنه إذا أنت فرضنا عم بتعالج non-small cell lung cancer with protons and you have not contoured the nodal stations involved, sometimes they get zero dose. So شوف انت هون الستاندرد فوتونز كيف في سبلاش دوز، والسبلاش دوز هاي مرات تحميك من ناحية inaccuracies of contouring. تفضل يا دكتورة سهى. هلا احنا باللونج كانسر انتوا بتفضلوا ان انا اتكلم بس بالانجليزي ولا يعني اخلط عربي انجليزي؟ is okay. What is easier for you? الاسهل لكم is okay. انا هخلط. يعني بصراحه انا عم بستعمل هذا التكنيك. انا يعني بدرس ناس دلوقتي في الجامعه في الاردن ويعني بيحبوا انه يسمعوا اكثر عربي. هلا احنا in lung cancer we use two main modalities, so CT scan and PET scan. And what is important is that when it comes to the CT scan, ideally بدك تعطي IV contrast إذا ممكن. طبعا بدك تشيك على الكرياتينين تبع المريض، بس إذا بتقدر تعطي IV contrast كثير بيساعد. بيساعد وين؟ بيساعد بالبريكيال plexus contouring كثير، بيساعد بالليمف نودال contouring لأنه بتبطل مرات ما بتعرف تميز ما بين الفيسلز اذا ما كنتش كتير ملم بالاناتومي والليمف نودز. Ideally بده يكون عندك PET CT scan for obviously diagnostic purposes. Sometimes you can do a PET CT scan specifically for planning purposes. But if you're going to do it for planning purposes, it has to be quite close in terms of time to your CT simulation. مرات في ناس بيحبوا يعملوا fusion ما بين ال PET CT scan وال CT scan. بس انتبهوا إذا بتعملوا هيك انتبهوا إنه ممكن يكون في a lot of misregistration between the images. فيعني you have to be very mindful of the registration issues that can occur. هلا الشغلة الثانية بدنا نحكيها المهمة هون إنه you have to pick the right window level. So إذا أنت في عندك تيومر كلياً في اللنج زي هيك you use the lung window. إذا في عندك تيومر بالchest wall يعني so lung tumor touching the chest wall or lung tumor touching the mediastinum, you have to use both window levels. A lot of time if you use the incorrect window level, you can underestimate or overestimate the tumor. If you're using PET CT scan for contouring, so you're registering the PET CT scan, it is super important that you use the correct window level, and that's usually pre-specified using the computer. Hello, when you come to draw the tumor or the gross tumor volume, in lung cancer, the current standard of care is to use a 4D CT scan. Can I just have a show of hands? How many people use 4D CT scan routinely for lung cancer cases? Anybody? Okay, does anybody do anything to kind of compensate for motion? Okay, how do you do that?
Calculate the freezer baseline. First patient in deep inspiration, then free breathing, and calculate the range of respiratory movement and contouring on the average.
Okay, so you do like an untagged, just free breathing CT scan, and then you do a deep inspiration scan.
Yes, yes. And see the range.
Okay, and you fuse them together, and then you get like an average position.
Yes.
So pretty much you do this time averaged position in a very clever, resource-friendly way, without the need to having the equipment for the 4D.
We have just a camera on the table of CT.
Okay.
Then the patient asks for deep inspiration, then free moving, and see the level between them.
All right. Yeah. Very good.
And the new one, catalyst, but we don't use them now. Catalyst, deep inspiration, but not on institution.
Okay. Thank you very much, Dr. Suha.
We use through the ABC, the
Active breathing control.
active breathing control, or we have a Vision RT surface.
So surface guided radiotherapy. Okay. So if you have the capability to do 4D CT, what that does is it reduces, so you then know your movement of the tumor, so the ITV, internal target volume, and that means that you can potentially reduce the margins that you take because you've already accounted for that internal motion. And if you have a 4D dataset, there is different ways of contouring on the 4D dataset. So some people would use what we call the maximum intensity projection, which is the maximum intensity of the different 4D datasets. You can use a combined exhale and inhale scan. You can potentially look at all of the individual phases, and you can do the time averaged position, which we kind of discussed now. And obviously the time averaged position is a little bit smaller than your MIP, generally speaking, because you're saying that I am happy to be hitting the tumor 80% of the time, for example. So what we do in my institution, so we don't have any planning PET. We don't even do PET for fusion. We only use PET as a guide, so we open it up on a different computer. أنا مرات بحس البت فيوجن مش كتير مفيد لأنه مرات كتير بالانتيريور تيومرز اللي هم قريبين على الزيفي ستيرنم والستيرنم a lot of misregistration can happen. وما تنسوا طبعا الكاوتش توب تبعت البت اذا هو diagnostic pet هي حقيقة مش straight، فانتبهوا يعني a lot of registration related errors can be introduced. We tend to contour on the MIP maximum intensity projection، واحنا بنسمي هذا الكونتور motion adapted GTV، ما بنسميه ITV. فانتبهوا على التسميات، تسميات مهمة انه تكونوا انتم متفقين شو التسميات. لا، so we do it on the maximum intensity projection of 10 phases of a 4D scan.
10
So
phases.
10 phases, yes.
Okay.
So this is the maximum intensity. This is something that is generated by the planning system, which takes into account the maximum density of all of the different phases. So pretty much it should capture all of the different phases.
Okay. This is
Yes,
different
please.
than the average.
It's different than the average.
For example, the patient have free breathing. Then I see the GT, deep inspiration, I contour more than one contouring or one.
So no, we just do one contouring and then we edit it. So again, for us, what we do is we start on the MIP. So you do your motion adapted GTV on the MIP. And then after that, you check each individual phase of the 4D scan, and you usually enlarge it if you think it's not, you know, if it's not drawing around the tumor properly. And I would say tricks are to be very careful when you're close to the diaphragm. لما تكون عندكم tumors واطية كمية الحركة كثير كبيرة. Sorry Mika for speaking a little bit of Arabic. So when you're close to the diaphragm الحركة بتكون كثير. لما تكون الحركة كثير you can very easily miss the motion. الإشي الثاني اللي تنتبهوا عليه الميدياستينم كثير صعب إنه الواحد يعني يتأكد إنه هو he's capturing the entire motion بالميدياستينم بالذات بستيشن 7. ستيشن 7 اللي هي تحت القراينة راح تلاقوا إنه الموشن تبعتها طبعا ستيشن 7 ممكن تنزل مرات الليمف نود لكثير واطي potentially في الميدياستينم. و you can يعني estimate the motion. الحل إنك تطلع على الكورونال images، دائما وأبدا نطلع على الكورونال images. وزي ما حكينا contour on more than one window if you have a lung tumor which is for example going to the mediastinum أو if you have a lung tumor which is causing to the chest wall. في حدا عنده anybody has any questions؟
أنا يعني حضرت قبل كده كورس كان حد بيعمل هايبرد بريث كنترول بال يعني بالكمبريشن.
اوكي.
عشان يقلل بس لما بيكون في التيومر lower in the lower side of the lung فبنعمل a sort of medium compression مش total compression عشان بس نقلل الويف مع ان هو بيبقى free breathing. Is it applicable?
So I would say it is applicable. We were thinking of doing this for cases treated with protons. لما تيجي تعالجي ببروتونز بيصفي في عندك مشكلة كبيرة يعني بسبب الريسبيراتوري موشن وبسبب المشاكل اللي ممكن تصير للبروتونز والاكيورسي اوف هيتنج ذا تارجت بسبب استخدام البروتونز في الحالات اللي مثل هيك. هلا generally speaking I would say people would tend to first of all examine the amplitude of motion of the tumor. If it's more than a centimeter sub-inf craniocaudally, I think applying abdominal compression for special cases is useful. I would say for photon treatments, I'm not entirely sure it makes much difference. And the reason is, so if you are doing SBRT, even if the amplitude is more than a centimeter, the target is usually quite small. But if you have super huge volumes, sometimes it does make a little bit of a difference, particularly in patients who are borderline and have borderline lung functions. It does introduce a little bit of complexity for the patient because a lot of the patients are quite frail and doing abdominal compression sometimes is not that easy. Do you have experience using abdominal compression?
I'm establishing my program. I will start
Okay.
the SBRT program of the lung by the beginning of next June.
All right.
So I read a lot. So I found this maneuver because sometimes the lung patients having a problem because this tumor is on top of COPD, on top
Mm,
of
mm,
lung
mm.
problem. So the wave of the respiration itself, sometimes it's very high.
Yes, you're.
Exceeding sometimes the 1 centimeter. So I'm just
I mean,
thinking of
I would.
hybrid, making a hybrid technique. This is not an official technique
Yeah.
or standardized, but
So
why not to do? If it is applicable. for the
you
patient.
can potentially
I
do
can
it.
put-
You can
yeah.
potentially do it. I'm not entirely certain you're gonna gain much in terms of toxicity
Okay.
reduction, and the complexity I feel associated with implementing it is a little bit cumbersome, I would say.
see if I do it, I will tell you.
Yes, please. So with regards to nodal irradiation, so we were speaking about gross tumor volume. Obviously applies to both nodes and primary. حاليا احنا راح نحكي عن النودز بالذات. هلا احنا بنستعمل اشي اسمه selective nodal irradiation. يعني we just only target the nodes if they are involved. So we don't do any elective nodal irradiation in lung cancer. مثل ما احنا بنعمل بالهيد النك مثلا. الهيد النك في elective nodal irradiation، باللنج ما في ابدا elective nodal irradiation. السبب الاساسي انه احنا في عنا هلا evidence جاي من small cell lung cancer from non-small cell lung cancer و even using IMRT that if you do selective nodal irradiation, the rates of isolated relapses in areas that you have not treated is quite low. So this is now the standard of care. So the question is that in case of induction chemotherapy and if the node completely responds, what do you do? If the node completely responds, you always include the craniocaudal extension of the node. So that area, I would say, is not considered elective nodal irradiation. You have to include where the node was, and that needs to receive full dose. You usually have this problem more in small cell lung cancer because you have huge lymph nodes and sometimes they disappear. The only thing that you're allowed to do is, because sometimes the node extends into the lung, so laterally it extends quite significantly into the lung. You don't need to chase it laterally, but you always chase it sup inf. With regards to nodal coverage, so we tend to utilize CT, PET scan, and EBUS TBNA. So just a show of hands, how many people have access to PET scan for lung cancer? Okay, so we have 3 participants. The others, you don't have access to PET scan. No. Okay. And how many people have access to EBUS? Endobronchial ultrasound guided biopsies? You don't do that. Okay. So you just rely on bronchoscopy, just regular bronchoscopy. No ultrasound guidance. You have it, okay. So ideally you would want to have these modalities. So you want to have EBUS TBNA and you would want to have a PET scan. And then dependent on these, you can say whether or not you're going to include that node. So obviously tissue always trumps everything. So if you have positive EBUS, so that means that the lymph node is confirmed to have cancer. Okay, احنا متأكدين 100% بالhistopathology. We always include that node. Okay, no question about it. If we have a lymph node which is PET negative and EBUS negative, بغض النظر عن حجمها. يعني حتى لو كانت lymph node كبيرة بس EBUS negative و PET negative, we exclude it. هلا مشكلتنا الأساسية لما يكون في عنا PET positive و EBUS negative، يعني discrepancy. صفى انه في اشي بيحكي شغلة الإيباس بيقول لك ما فيش فيها disease والبت بيحكي لك فيها disease. فشو بتعمل بهاي الحالات؟ أول إشي لازم تطلع على ريبورت تبع الإيباس وتحكي مع الشخص اللي أخذ السامبل البالمونولوجيست. هل هو was he confident that he hit the lymph node? This is number 1. Number 2, هل في lymph tissue بالhistopathology؟ الhistopathology ده بيحكي لك this is adequate أو inadequate sample. كثير مهمة هاي المعلومة. لو في lymph tissue in the sample, this means it's adequate. يعني you have to take it into consideration. ولكن لما تكون PET positive و EBUS negative, the chance of this being involved is quite high. شوف 16% لو كانت هي enlarged و 14% لو normal sized on CT. In these cases, according to ESTRO-ACROP guidelines, we tend to include these nodes. You always tend to err on the side of caution if you are a little bit unsure. So this is what I can tell you. I don't know, Dr. Ming is now in audience. What do you do in your practice in the US? Dr. Ming is now from Columbus, Ohio, yes? But she's moving to Rochester. She's a radiation oncologist from the US. Hello. So do you do anything differently?
We do not do elective nodal irradiation, only do the what we believe as high risk and positive lymph nodes. If lymph node is enlarged, PET was negative, then we get a bronchoscopy EBUS to evaluate that.
Mm-hmm.
Exactly how you described.
So the only, thank you very much, Dr. Ming. The only reason I would say sometimes it's okay to exclude a lymph node which is PET positive, EBUS negative. I would say the only reason you can exclude it is that there is a reason why this lymph node is lighting up on PET. Sometimes the patient has sarcoidosis, for example, and this causes the lymph nodes to light up on PET. So there is a reason. And importantly here, you need to have repeated EBUS sampling. I would only be comfortable if you have 2 EBUS samples which are negative. And this is just to answer your question about if you have complete remission within the node, the whole anatomical area, that's craniocaudal extension, needs to be included. And that is, I would say, standard of care. What about if you have complete remission after induction chemo or sequential chemoradiotherapy in the primary? What do you do? Does anybody know? Or what is the practice? Dr. Ming, have you ever seen this situation where, for example, you treat small cell lung cancer and you have complete remission within the primary?
So that's a very good question. There is a study by Dr. Keel, before, and then in that study, she showed that if you do pre-chemotherapy volume versus post-chemotherapy volume, the outcome is the same.
Mm-hmm.
But at that time, the practice was to treat the entire mediastinum. So I think what that study really alluded to is that you could reduce your GTV volume if the primary size of cancer got smaller. But you cannot say confidently about nodal. So that study has not been done.
Yes.
See what I'm saying?
Thank you very much. So in our practice, obviously, the craniocaudal extent of the nodal disease we always include. The primary, in the rare situations, I think I've only seen 2 cases where the primary has completely responded, the primary in the lung. And we always debate these cases. We never know the answer. I think if there's completely nothing in the lung, you can't even see any faint change within the lung tissue, you are no longer sure where you're hitting, by the way. So we don't tend to treat these. But if there is some change, irrespective of how small it is, I would always err on the side of caution and treat that area. So just also another issue is that you can, yes, please. طبعا, of course, we can use the PET, and sometimes if you have sequential chemoradiotherapy, sometimes you do PET after chemotherapy, and it sometimes is very useful. But we are talking about the situation where the tumor completely responds. You mean to fuse with the previous images?
With the initial.
You could potentially. But in the lung, I would say in the mediastinum, you're always sure because you have like nodal anatomical boundaries of the stations. So you know the station 4R is, the cranial extent of it is this much and the caudal extent of this is this much. So you're always sure where you are. But in the lung tissue, you're never 100% sure because sometimes the lung tissue changes a little bit with treatment. So this is the complexity that you have.
Fusion with initial PET will not.
It can sometimes help. It can sometimes help. We're going to talk about the CTV margins now. This is a study from a surgical resection series, which evaluated the microscopic extension around the tumor. And this study shows that you can capture 95% of this microscopic extension if you have a 6 millimeter margin for squamous cell carcinoma, while you need 8 millimeters for adenocarcinoma. So based on this, you can have different CTV margins for different primaries. Although I have to be honest with you, we tend to utilize the same margin for irrespective of histology. So we tend to utilize a 5 millimeter margin irrespective of histology. And this is a less known study which does the same thing. So this is extracapsular extension amongst 243 non-small cell lung cancer surgical resections. And what they found is that 95 percentile of the extracapsular extension, the distance depends on the size of the node pretty much. So if you have a big node, so more than 2 centimeters in size, you need 8 millimeters. While if you have a node which is less than a centimeter, you need a smaller margin. And again, you can potentially utilize this to guide your margins. But I would say measuring nodes might not be that simple. So again, you can simplify things. Anything between 5 and 8 millimeter CTV margin, I think, is appropriate and is what is recommended in the literature. The other thing to consider for nodal CTV, so bear in mind this is the nodal GTV. So you have two approaches. You can just do an isotropic margin like this, or the other approach is you do an isotropic margin, and this is here station 4R. And after that isotropic margin, you can extend and expand your CTV to make sure that you include the entire anatomical boundary of that nodal station. Again, bear in mind, we're not doing elective nodal irradiation. We're just including that nodal station anatomical boundary of where that involved node is. So we're just including, because there's a station 4R node which is involved, we're just extending that CTV boundary to make sure that we're capturing the 4R anatomical region. Again, what do people do in their practice? I would say either approach is absolutely acceptable. I think if you have a re-irradiation case, I would tend to use this approach because it means smaller volumes. So it depends on the case. Again, there's a little bit of subjectivity. If you have a lot of dirty looking nodes, even if they're quite small and they're quite close to that big involved node which is lighting up on PET and we know it's involved by EBAs, I would tend to be a little bit more cautious and just, you know, make sure that I'm capturing this with my CTV margin. Again, any practices which are different, or does anybody have any comments here or questions? Dr. Ming, yes? Yes.
Okay.
Yeah.
So then I feel that your CTV margin doesn't have to be as extensive if you, you can be more confident about not having such a large margin if you have 40 CT.
But
so
wouldn't-
you included the motion of the mediastinum.
But I mean, don't you think that you still need a CTV margin for that microscopic extension?
Oh, absolutely.
Okay.
But I'm just saying sometimes you want to reduce it in
Yes.
a radiation setting.
Yeah.
So I feel that sometimes, for palliative setting, for instance, and my margin is larger because I'm now using 4D, but then you feel you're confident about how good your CT simulation is with 4D, then you maybe feel more comfortable reducing that CT margin.
Yeah, that's absolutely a good comment, and I'm gonna, after we try to get you guys to do some on-site hands-on contouring, I'll show you the guidance that I have for you for re-irradiation. And yes, definitely, in re-irradiation cases, if you're worried about organ at risk doses, you can potentially drop your CTV margin down to 0 if you're super worried about, an organ at risk nearby. And this is just a reminder of the International Association for Study of Lung Cancer nodal mapping, which gives you the different boundaries and shows you exactly where the different nodal stations lie if you want to apply this approach. And lastly, we will touch briefly upon the PTV. So the PTV takes into account patient setup uncertainties. Bear in mind, you've already taken into account the motion of the tumor, so the internal target volume has already been done because you've done a 4D scan, or you've done something which is resource friendly within your setting, which potentially captures that motion of the tumor. And this is obviously based on your local data. And while editing of the CTV, like we said, is allowed, editing of the PTV is not allowed. So I'm gonna stop here. Obviously, I have some teaching material for organs at risk, and then I have some teaching material for the re-irradiation case specifically. But I'd like maybe to give you a chance to contour the GTV on both the initial case, the re-irradiation case, and then the recurrence. So I don't know if we can maybe sort out, have we got any laptops or no? Okay. So how many people have laptops in the audience? 1, 2. Okay, so we have 3 laptops. So may I suggest maybe that maybe you 4 do the contouring together? You guys have a laptop? Okay, can you maybe also do the contouring together? And then Dr. Suha, you have a laptop or? No, so I can give you my laptop, okay? And we'll give you, so we want you to do the gross tumor volume for both re-irradiation case 1 and re-irradiation case 2. And then we'll go through the contours. And then after that, we'll go through organs at risk. We'll give you maybe 20 minutes for this.
الناس اللي معاها اللابتوب عرفوا الباسورد بتاع النت.
الواي فاي هو orange والباسورد